us today?
I was just going to thank everybody for coming. It's a really fantastic roll-up. If anything, it's testimony to what we've been trying to do with the P6 for a long time. So really thank you very much from the bottom of my Ames Tropical Division heart. So I'd really like to include you all in APACE. So those of you that are viewing remotely, are you able to just by return email or to my email address, just a quick thing to tell me that who you are and where you viewed from, and I'll keep that on file. And then Ames, if you ever want your APACE certificates to promote your continuing professional development, I will be happy to provide that for you, and that gives you a little bit of, I guess, fact checking for the people who audit that. So thank you very much. I'm not going to talk on for too long because Lyndall's got a great presentation. And for the remote sites, I'm really sorry, but she's bought chocolates for us. So if you do get the quiz questions and we don't get any here in Townsville, I'll send you a box of chocolates, all right? Thank you. Thanks, Lyndall.
Okay, so thank you everyone for coming and for viewing remotely. So I'm talking on leukemia tonight, and I think we all have an interest in this in the haematology field, and so a little bit of history first. So leukemia's been around for a long time, or it's been noted for a long time. So in 1825, this Armand Velpau, now he was a man who lived a life of spirituous liquor and of women, so he had a good life for a short period of time because he died very soon after he presented to hospital with abdo pain and fever, and it was noticed on his autopsy that he had a huge spleen and his blood resembled thick pus. So that's thought to be the first case of leukemia that was recognised, that there was something in the blood that was causing that. Later on, in 1846, a doctor at St George's Hospital in London saw the first case of what was probably a chronic myeloid leukemia, which was called chronic granulocytic leukemia in those days. And so he examined this patient's blood after death, and he found these big globules in the blood, and they would have been all the white cells. So there was a large number of these big blobs in the blood. And Virchow in 1847 found a similar case, and he was the first to use the term leukemia, meaning white blood. However, John Bennett from Edinburgh beat Virchow to the post and published a case first. So there was a first description probably in 1845. So leukemia's been around for a long time. We know that in England they noted that there were a lot of childhood cases of leukemia in the 1930s. They thought it was attributable to the introduction of electricity and power lines. And who knows what power may be doing today in the pathogenesis of leukemia. So it was more evident in those states where there was power connected. So we know that leukemia results from a neoplastic proliferation of cells. So it's a mutation of a single stem cell, and often there's a lot of genetic alterations that lead to leukemia. So you've probably heard about the two-hit oncogenic theory, and so that, may be true in leukemia as well. So the genetic events could be that there's transformation or inappropriate expression of oncogenes, or a decrease in the function of the tumour suppressor genes, and we see a deletion or a reduction of P53 in some of the leukemias. So leukemia is generally classified as acute or chronic, depending on the presentation, whether it's sudden or whether it's evolved over a long period of time, and then we can classify it according to the particular cell lines. Is it lymphoid, is it myeloid, or does it have features of a couple of cell lines, like biphenotypic? So if we've got that mutation way back in the stem cell, we can see that the pluripotent stem cell gives rise to the specific stem cells and all the cells that we see in the peripheral blood. So in acute leukemia, we're not getting differentiation of the cells. They're staying in an immature state or a blastic state. They reproduce and they multiply very quickly. So there's a defect in the maturation. And so there's an imbalance between proliferation and maturation, so you're getting that leukemic clone expanding, and it's got a survival advantage over the normal cells. So the acute leukemia is going to develop very quickly. So chronic leukemia has this expanding pool of cells, but they're still able to differentiate. Now their function may not be as normal as a normal cell in their mature state, but we're seeing a lot of normal cells in the peripheral blood. And these will stay in the cells in the blood for a lot longer than the normal white cells. And quite often they're not capable of fighting infection. So if we look at the distribution of leukemias according to age, typically in the under 20s and particularly in the young children, you get a predominance of acute lymphoblastic leukemia. Chronic lymphocytic leukemias tend to be in the older age patients. Myeloid, is across the board, but it typically is in the middle-aged patients. CML, mainly in adults, but in any particular age group. So again here we've got the leukemic stem cell, undergoes a mutation, produces this group of leukemic blasts. Chemotherapy might kill off most of those cells, but there may be some that remain, and they are capable of causing a relapse. So the aim of therapy is to get rid of as many leukemic cells, and you'll know that they have like a initial induction therapy which gets rid of most of the cells, and then consolidation and maintenance therapy to try and get those occasional cells that might be able to repopulate and cause a relapse of the leukemia. So in acute leukemias, we've got the increased proliferation of the cells, but we've also got a decreased death of cells. So they're not dying, they're staying there, and they're not differentiating. So the symptoms of leukemia are due to the proliferation of these cells into the various tissues. And they also have metabolic consequences as well, this increased cell proliferation, and they disturb the normal tissue function. So the symptoms we see, anemia, and they're the general symptoms of anemia, pallor and lethargy. Also the bone marrow is going to be crowded out by those leukemic cells, so often the patient might actually have a peripheral cytopenia, but they're going to have a marrow that's packed with leukemic cells. There's also ineffective erythropoiesis, so the normal cell production's not happening. Night sweats can occur due to cytokines that are released from the malignant cells, but also to the metabolic processes happening in those leukemic cells. Of course, patients may present with neutropenia because if they haven't got many neutrophils, because the leukemic cells have taken over, they're going to be prone to infections. The same with the platelets. There's not much room for the production of platelets, so they're going to have bruising and bleeding. Okay, and here's some ugly pictures of leukemic symptoms. So in this patient, they've got an infiltrate of leukemic cells into the eye. So a big pussy sort of area there. This man's got an infiltrate of leukemic cells into the skin, and it's caused this vasculitis. And you can get these gummy lesions as well, where the cells, particularly monocytic lineage cells, infiltrate the tissue of the gums. So children often get joint pain. That can be a presenting symptom. Maybe they're, having difficulty walking. So the bone pain is because these cells are just proliferating in the bone marrow, and that's causing a lot of pain. There's pressure on the nerves in the bone marrow. In rare cases, you may actually get avascular necrosis of bone, where some of the bone is dying off, the blood supply is being cut off, and so they often get that post-treatment, but it can be an initiating symptom. Splenomegaly, of course, that's common in things like chronic myeloid leukemia, so patients might be complaining of fullness or, a swollen sort of tummy. Hepatomegaly, and we said the monoblastic, you can get infiltration of the gum and the skin. And of course, promyelocytic leukemia is one that is particularly nasty if we don't pick it up straight away, because it can cause DIC, and it's the DIC that will kill the patient very quickly, often within 24 hours. So here's some more pictures. Here's some skin lesions in acute monocytic leukemia. Some of the congenital leukemias which babies can get in the first 4 weeks of life They refer to the babies as having a blueberry muffin rash, and it's really these monocytes that have infiltrated the skin. DIC, which has caused this gangrenous hand here, the typical bruising, the lumpy neck or lymphadenopathy in the ALL, and here's a big spleen here. So the spleen normally is the size of a clenched fist, so quite often it can be really, really large. So here, a treatment typically for ALL, we'll say, induction chemo. So if we consider that the patient with ALL might have 100 billion lymphoblasts when they're diagnosed, induction chemo might kill 99% of them. That means they're still left with 1 billion lymphoblasts, which are capable of replicating. So that's why we need the later stages of therapy to try and carve out those lymphoblasts so that they don't get a relapse. So they have consolidation therapy and then the maintenance, which may go on for about 2 years, the maintenance therapy. Some of the worst prognosis leukemias might be better to have a transplant, and that's available for some of the poor prognosis ALLs and certainly the AMLs. So little puss there is not looking too happy after chemo or shave, whatever he's had. He's lost some fur. And then the response to treatment, well, the good news for children with ALL is that there's a really good cure rate. There are some that aren't so good, and AMLs in any age group aren't very good. And so the 5-year survival rate for people with AML is 26%, so quite dismal. So the blast cells in leukemia are neoplastic, so they're going to be different in morphology and metabolism from normal blasts that we have as our precursor cells. So the leukemia cells, they like glucose for energy, and that helps them to grow. So in AML we might see some hour rods that can be particularly diagnostic for an AML, although we have seen some hour rods, hour-like rods in lymphomas. But typically these ones are coalescence of the primary granules, and that indicates a myeloid lineage. And faggot cells are where we get bunches of these hour rods, and they're typically in promyelocytic leukemia. We might see in a leukemia, if you're suspicious of a case being a leukemia, always have a look at the LDH, because that quite often will be increased because the products of cell turnover will increase the LDH and urate. So that's always a clue, and it's a good clue if you are monitoring a child with ALL. Always look at their LDH as you're doing their follow-up counts, because if that sneaks up, you know, maybe they're going to be relapsing, and you might want to just check closely for any blasts. Okay, the morphology. Chromatin pattern is very important in blast cells. It was easy when we had the FAB classification. We had, you know, our 3 lymphoid blasts and our 7 myeloid blasts. The WHO classification has made it a lot more difficult. So we have small lymphoblasts, which these are the type we get in the childhood ALL. Very hard to recognise as blasts sometimes, very scant cytoplasm. Nucleoli can be inconspicuous. So what you've got to do if you suspect that it could be an ALL, and maybe that might be because the child's got a low hemoglobin or platelets, is to compare that with a normal lymphocyte on the film. You're going to find a normal lymphocyte somewhere. And just compare and think, does that look different? Oh, there's hardly any cytoplasm. It's a little bit bigger. The chromatin's a little bit different. So it could be an ALL blast. In the adults with ALL, their blasts tend to be a little bit bigger and a bit more variable. And we know the adult ALLs don't have that good cure rate like the kiddies do. And theirs are a little bit larger, the blasts. Burkitt, of course, we don't see a lot of these. And they have a really vacuolated cytoplasm and intensely basophilic blue staining. And we'll talk a little bit more about those later. But these are the Burkitt lymphoblasts, and, you know, we call them leukemia. Histologists like to call them lymphoma, so they're called leukemia/lymphoma. Everyone wants a bit of them. Myeloblasts are much easier to recognise. They usually have a bit more cytoplasm. The chromatin's a bit finer, a bit lacier, And the nucleoli are usually easier to pick, so a prominent nucleolus in this one here. And if you compare that with a lymphoblast, there you can see there's a little bit of difference. And I'm sorry, the magnification's different. I'm not trying to trick you. Okay. Monoblasts, these are the biggest, ugliest blasts you'll find. You know, they can be quite blue. You could sort of confuse that perhaps with a Burkitt cell sometime, but quite large. So here's an AML on the left compared to an ALL. Okay. So what do we do if we suspect leukemia? Well, we know we've got our full blood count. That's how we might recognise in the first place. We're looking for immature forms. We're looking for the increase in the urate and the LDH. The coags might be off, particularly if it's an APML. And of course, the doctors might want to look for a mediastinal mass if we suspect a T-cell disorder. Okay. So we will need a bone marrow aspirate. We will need flow cytometry if we've got lots of blasts there. Not much use in a CML where you've only got occasional blasts. We'll need cytogenetics. Now that's very important for CML. We might get immunohistochemistry on some of the marrow slides. Patients obviously might need CT scans of chest and brain and spine, so other examinations there. So the WHO classification, very clumsy. It's going to change again soon. We've had the papers out on it with the 2016 classification, which is now 2017, and the book will be out soon, I gather. So a few changes from the 2008. So we had a bit of difficulty with WHO because now we're getting a lot more chromosomal abnormalities in leukemic patients, so that's got to be included because that's really helpful in diagnosis. So we've got a few different categories here: the recurrent genetic abnormalities, the multilineage dysplasia, the therapy-related, not otherwise categorised. Is a very handy box for something that doesn't fit, gets chucked into there. Okay, and for ALLs, we've got the Bs, the Ts and the Burkitt. Okay, let's look at acute myeloid leukemia. And we get a lot of molecular alterations, and as I say, they're finding more and more translocations and molecular changes all the time, particularly now that we've got microarray analysis to help with diagnosis. So we know that in leukemia, these normal regulatory networks are disrupted, and so that's going to affect the functioning of the cells. Okay, so what do we do for markers? Well, let's look at what lineage, what markers are helpful in what lineage. So CD13 is a myeloid, so is CD34. CD33, sorry, CD34 is an early precursor or stem cell marker. HLA-DR is positive in most AMLs, negative in promyelocytic. 11B is a monocytic marker, 14 is a monocyte marker, 41 is a platelet glycoprotein. Okay, more here. So we've got more of the platelet glycoproteins, the glycophorin and the erythroid leukemias, which are extremely rare, I'd have to say. TDT can be lymphocytic leukemia, but also in the undifferentiated myeloid leukemias. 11C myeloid and 117, which is c-KIT, is a myeloid stem cell marker. So if we look at the genetics, a lot of the AMLs will have a normal karyotype, in fact the majority. And some will have specific chromosomal translocations, and others might have, a smattering of various ones. So the recurrent genetic abnormalities, we have some good risk ones, and then we have some bad risk ones. So we think of inversion 16. Now this used to be the M4-EO in the old FAB classification. So this is a myelomonocytic leukemia with eosinophilia. Inversion 16, that's a good prognostic indicator. Monosomy 5 and 7, really bad. These FLT3 mutations are quite bad as well. Okay. So if we get a patient that we suspect is an acute promyelocytic leukemia, we will take the blood to our genetics department right away to fish for the 15-17 translocation. They can get that done in a few hours before a bone marrow is even organised or collected. So it's handy to have that because we know about the poor prognosis of promyelocytic leukemia if it's not treated straight away. We also like to evaluate the marrow for these FLT3 and nucleophosmin mutations because they're not very nice, and sometimes you might see blast cells that have got like a cupping mark in the nucleus or a thumbprint, and quite often it will be these cases that have these mutations that show those changes. And we've got some other mutations down here that we might find. So we're getting more and more of these molecular changes that are helping tailor the diagnosis and making it a little bit finer so that the treatment can be more targeted and hopefully more successful. And that will, be continuing over the years to come because there's so much work happening in those areas. Okay, this 821 translocation, usually young age patients, the blast can be a little bit variable. They can be have a bit of maturation, so it might be like the M1 of the FAB classification. They can have some eosinophil granules, so M1, M2 in the FAB classification. Cytochemistry, they're going to be myeloperoxidase positive, and they've got those myeloid markers and stem cell markers there, the 13, 33 and 34. And this is a typical example of the blast. So cytoplasm, a few granules in this one here on the left, maybe a few granules there as well. In version 16, we said this is a good prognosis. Interestingly, although this has got an eosinophilia in the bone marrow, it doesn't have that in the peripheral blood. So it's a bone marrow eosinophilia with the myelomonocytic pattern, and that's why we've got the 11s, 13, 14 and 33. So they're myeloid and monocytic markers. Here's an example here. Some of these monocytes are really dysplastic looking, aren't they? They get that really bandy looking nucleus and almost like a neutrophil. They're sort of a hybrid cell between a neutrophil and a monocyte. And we've got a blast there, some blasts here. And in the marrow, it's a bad photo, but there's, this eosinophilia with some eosinophil precursors. You might have heard about core binding factor AMLs. And these are either ones with the 821 or the inversion 16. And they tend to have a favourable prognosis. Okay, we spoke about APML. Not very good if it's not picked up. And it's one that we'd expect our scientists to be able to recognise. We don't really care if there's other blasts that, we think, are they myeloid, are they lymphoid? We'll find out with the marrow and the markers. But if we've got the classic features of APML, we need to let the doctor know that straight away. So this can occur at any age. They're abnormal promyelocytes. In our labs, we count the abnormal promyelocytes as blasts because that's the leukemic population, and they're certainly not the same as the normal equivalent of promyelocytes. We can get a hypergranular and a microgranular variant, and both of them are associated with DIC. Okay, so here's one of those faggot cells. So it's got lots of hour rods there, bunches of them. Most of these patients will have the 15-17 translocation, and that's good because the fusion gene that forms, which is the promyelocytic retinoic acid receptor gene, allows for the treatment by all-trans retinoic acid, which is half of the vitamin A molecule. The Chinese discovered it some years ago, cheap treatment. And they used to use it alone, but it didn't result in a sustained remission of the leukemia. So it has to be used now in conjunction with other drugs like arsenic trioxide or other chemotherapy like daunorubicin, etc. So it's good if they've got that translocation. There's other translocations as well. There's the 11, 17 and some others that you might find in APL. So I've got odd socks here. It's a translocation, so it looks like they've swapped socks here at the bottom, so the chromosomes have this reciprocal translocation. And here we're showing here the promyelocytic retinoic acid, we call it RARA. This receptor here is able to bind to that all-trans retinoic acid. So patients often present with bleeding symptoms or bruising that might be out of alignment with their platelet count. So their bruising might appear a lot more severe than their platelets suggest. And it's because of this DIC. So the tissue factor can leak from those granules. The problem is if those cells die and those granules are released into the serum, they're going to have procoagulant activity and they'll initiate the coag cascade. And you get sort of clotting and bleeding resulting from the coag factors and the platelets being consumed in that clot. And yes, there's a nice bruise, classic presenting symptom. And here you can see that, there's leakage of the blood out into, the ventricles of the brain in a case of APL. And here we've got this subarachnoid hemorrhage and splenic infarcts from the clotting process. So it's this paradoxical clotting and bleeding at the same time. Okay. So we said that we need an early diagnosis because the DIC will kill them a lot faster than their leukemia. Okay, and we said there's a hypergranular and a microgranular variant, so they can both get the DIC. The white cell count tends to be low. You get that typical pancytopenia in your hypergranular or high white cell count in your microgranular. The nucleus is sort of bilobed. It can be the sliding plates, it can be the butterfly or the angel wings. You may not see that formation so much in the hypergranular because the granules might be hiding that a little bit because they're so densely packed. Okay. So we describe the nucleus as reniform or bilobed, and our doctors like butterflies. I don't know how you see them. And so those granules are the coalescence of those primary granules. Sometimes you'll get fine granules, just like a fine dusting. So there's a cell there, and it's got some big chunky our rods and a couple of finer ones. This one has got the two sliding plates and the granules. Here's the butterfly wings. I like to think they're like a set of lungs with the division. It's all very subjective, isn't it? So the variant tends to have the minimal rather than the excess granulation. Sometimes it's better to see that nuclear structure when they're the hypogranular. Like that one there, so it's got the two sliding discs or plates. You can get a rare variant of promyelocytic leukemia that's got basophilic differentiation, and they look to have granules a little bit like Shediac-Higashi. Okay, so the therapy's got to be carried out on two fronts. So we need the retinoic acid and chemotherapy for the leukemia itself, and we need to control that bleeding diathesis. So they're going to need low molecular weight heparin straight away, and they might need some FFP as well. So the arsenic trioxide, I don't know how you'd feel if your doctor said, I'm going to give you some arsenic. I wouldn't be too happy, but it works very well in combination with the retinoic acid. Okay, so the induction can be the ATRA, all-trans retinoic acid, plus anthracyclines, or it can be arsenic trioxide. And then for consolidation, they're just going to have the chemo. Maintenance, they're going to have some ATRA and low-dose chemo. And then we're going to monitor for that fusion gene, because if we can get them to be hematologically and cytogenetically in remission, then that's virtually a cure, isn't it? Okay, so this is trisonox, so this is the arsenic trioxide, so it degrades that fusion gene protein and it enables the cells to differentiate again. So that's good. That's what we want. We want the cells to differentiate. So ATRA is a differentiating agent. So the cells, although they're abnormal, instead of dying off and releasing all those yucky granules, they're going to mature into reasonable, neutrophils. They look a little bit funny, but
sometimes I get that, like the tumour lysis syndrome.
Yes.
So what's going on? What's the mechanism behind that? If the drugs usually...
Well, if you've got a really high white cell count, when those cells are broken up, this particularly happens with really high white cell count. So all of that protein is quite toxic.
And potassium.
Yes, it's quite toxic to the kidneys.
So are the cells, when you give them that chemotherapy drug, if it's just making the cells differentiate, technically they shouldn't be breaking up, should they?
No.
Or is this
no.
just incidental?
Yeah.
If it's
I
just
mean,
very high
if they're having some of the, say, daunorubicin or idarubicin therapy with their atra, you might get some, but it's not going to be as much. And hopefully by that stage you've got them on the low molecular weight heparin and, you know, that's sort of a little bit controlled.
So they just have to cross their fingers and hope.
They can get a retinoic acid syndrome, unfortunately, which can be a side effect of retinoic acid therapy where they can go into respiratory failure, etc.
Okay.
So that's one side effect of atra.
But they just have to do it because they don't really have an option.
No. And before they had atra, all patients with APL died very quickly. Yeah, so it's a good advance. It's one of our success stories, like Gleevec and CML. So this is about retinoic acid syndrome. So we said atra stimulates the differentiation of the leukemic cells to mature cells. It also helps control the DIC, but the patients won't have a sustained remission with just atra alone, and that's why they have to use the other drugs like arsenic trioxide. But this syndrome where there's fever and respiratory distress occurs in some patients on retinoic acid. So usually 2 to 21 days after, it's sort of a bit like a transfusion reaction, isn't it? And so these patients have these lung infiltrates and pleural effusions. It's a risk, I suppose, you take. You have, you know, you have something,
really,
you have something, or Okay, AML with 11q23 abnormalities, usually in young children and babies, usually monoblastic or myelomonocytic. I haven't really seen any of those cases. Their genetics, they have chromosomal translocations involving chromosome 11, so it could be a 911 or 1119. They've got the monocytic markers here, the 11s and the 14s, and the myeloid markers of 1333. What we do see a fair bit of is these AMLs with multilineage dysplasia. So these are the elderly patients generally, and they could be pancytopenic, and they'll have dysplasia in many of the cell lines. So AML with multilineage dysplasia, of course any of the AMLs are going to have 20% blasts or more in the peripheral blood, and they have to have dysplasia in at least half of the cells in at least 2 lineages. This is where WHO becomes quite complex, doesn't it? And so we're going to be seeing more of these complexities. So the AML minimally differentiated, these were like the M0s in the fab, you know. We're not really seeing the granules, we're not seeing any cells that are maturing up to early myeloids. And only 5% of AML cases are these minimally differentiated ones. So comparing those without maturation to those with maturation, the AML without maturation, a high percentage of marrow blast, greater than 90% of the non-erythroid cells. And they can still have positive myeloperoxidase. They may or may not have ARROS. The AML with maturation, you're going to have some other differentiation of the myeloid cells. So we probably don't need to do too much on that. Acute myelomonocytic leukemia, so the ones involving the monocytes start to get a bit nasty. And some of these patients may have arisen from CMML, and typically this is in older patients. So you might see CMMLs or your myelodysplasia start to transform and develop blasts and immature monocytes. So again, we've got those myeloid and monocyte markers, and we can do a lysozyme and get a positive result there. This is the gum hypertrophy in a pregnant woman with myelomonocytic leukemia. So you can see how that swollen that is and how she's been bleeding into that gum. So pretty awful. And I think you'll be going to the doctor with that. So acute monoblastic and acute monocytic leukemias. Here's some more gums here, overgrowing the teeth. So that's typical because monocytes infiltrate mucous membranes, respiratory tract, GI tract, skin. So they often get this skin rash from the monocytes infiltrating the skin. If they were to biopsy any of these spots, they'd be full of the monocytic cells. And so these monoblasts are big, ugly blasts. If you have an acute monoblastic leukemia in the bone marrow, you have to have more than 80% of a combination of monoblasts and pro-monocytes. If it's less than 80%, it's called acute monocytic leukemia. So there's an acute monocytic leukemia. So you can see there's a bit more differentiation of the monocytes. So we can see a couple of blasts here. Some of these cells are probably pro-monocytes. And again, here, a lot of these cells are probably pro-monocytes. They've got that dusting, fine dusting of granules, and still got some nucleoli and quite fine chromatin, but they're not those big blasts that don't tend to have those granules. Another picture there. Erythroid leukemia, we don't see these very often. In the WHO classification, they're either an erythroleukemia or a pure erythroid leukemia. And it depends whether there's a myeloid component or not. So it's very rare. You might get some bizarre nucreds, flowery nuclei. Vacuolated erythroblasts, particularly that would be in the bone marrow there. Acute megakaryoblast, again, more than, quite rare, but more than 50% of cases are going to have these megakaryocytic lineage cells. And we had a look at a couple today at the lab at QML of cases of myelofibrosis that had all sorts of bizarre megakaryocytic precursors in the peripheral blood. So they're quite ugly. Often the megakaryoblast have got little pseudopodia, like little platelets budding off them. That's how we might recognise them. And we'll often have these circulating megakaryocyte fragments, etc. There's a couple of pictures there. One of the pseudoleukemias that we see in Down syndrome is a megakaryoblast leukemia. So it spontaneously disappears in most cases. So it appears like an acute leukemia, an acute megakaryoblast leukemia. These children often have more blasts in their peripheral blood than they will in the bone marrow. Obviously, any doctor who's got a child, whether they're Down syndrome or not, if they've got a lot of blasts, they're going to do a marrow. So they're going to be surprised that there's less blasts in the marrow. And the only chromosomal abnormality might be their trisomy 21. Sometimes you might sort of find an acute leukemia and you might ring the doctor, it might be a child, and you might say, oh, your child is, this patient's got acute leukemia, and they'll say, oh no, you must be wrong. They're well, and their hemoglobin and their platelets are normal, and you sort of say to them, oh, does this child have Down syndrome? And if they say yes, you can probably say, well, it's probably this pseudoleukemia, which will resolve in about 3 months. Unfortunately, some of these children within the first 4 years of life will get a true acute leukemia. So, yeah, and because children with Down syndrome are going to have chromosomal instability anyway, so they're more likely to have damage to their chromosomes, so they're going to be more likely to develop an acute leukemia whether they've had the pseudo one or not. And so here's a film here, so you can see there's plenty of platelets in the background. There's a megakaryoblast. There's a little bit of heparin contamination around these red cells, so the child was probably a bit difficult to bleed and they might have had a heparin line in. Okay. Congenital leukemia, and we don't see many of these. These have to present in the first 4 weeks of life. So they've developed in utero and they've presented in those first 4 weeks of life. So they tend to be monoblastic in nature. These kids tend to get that infiltrate in the skin, the blueberry muffin baby, and they might have an increase in hemoglobin F more than a normal child. So the proliferation of these cells can go into, other tissues, we said. So this is the blueberry muffin rash in a child. This is not the only cause of a blueberry muffin rash. There's lots of other causes, but the congenital leukemia is one cause. And again, if they were to biopsy those little spots, they'd be full of monocytes. And it's what, when you get that leukemia in the skin, it's referred to as leukemia cutis. And this little child's got lung infiltrates and hepatosplenomegaly, really quite big there, isn't it, in a congenital leukemia? Okay, so they have suspected that there could be exposure, either parent might have had some exposure that's resulted in this congenital leukemia. So, you know, they used to talk about the emerald clusters of leukemias, and they think, you know, maybe dad's been spraying pesticides or spraying the pesticides on the bananas at Coffs Harbour. Maybe mum's been smoking a bit of pot or drinking, and that's resulted in the congenital leukemia. I don't think they really know what it causes. Basophilic leukemia is extremely rare. I've met a lady who had basophilic leukemia and had a transplant, and she's still going 10 years post-transplant. So, yeah, they are around. And a bit hard to recognise. So let's get on to the lymphoblastic leukemias. So this is due to the abnormal expansion of the lymphoblasts, and they're going to replace the normal marrow very quickly. You can have a child that presents with pancytopenia, which is quite typical, and the bone marrow can be absolutely packed with the lymphoblasts, but they just haven't been released at that stage. In time they will be, of course. And they can infiltrate other hemopoietic tissue. So they think that ALL develops in two stages, a prenatal stage and a postnatal, which could be up to 10 years after the birth of the baby. You know those little spots that they do on the blotter for the babies when they're born? They've had some researchers have a look at those spots. They've had a look at the genetic translocations in those spots in children that have developed acute leukemia, and the translocation was there then. So it's been there all along. They've needed another mutation, another event to set the leukemia in motion. They know in England, yeah.
So you mentioned at the start of your speech that ALL often presents with bone pain, but if it's appearing in children 10 plus, is that sometimes just disregarded as growth pain? Is that
well, it could be. It could be, yeah. We always worry when we get a child in with a history of a limp, or you think, oh, I hope this isn't going to be a leukemia. And it could be anything. It could be juvenile immune arthritis. It could be anything, yeah. But because of that expansion of the blasts in the bone marrow, that's going to cause pain. You get that same pain with patients who are on GCSF therapy because they're trying to get the neutrophils to rapidly increase. They're going to get bone pain as well. So patients that donate stem cells will tell you about how painful their leg bones become. Yeah, and patients on chemo that have GCSF, they get terrible pains in their spine and that. So it's because the cells are rapidly expanding and, you know, probably affecting the nerves. So leukemia can affect the ocular tissue. So this little kitty's eye, they've got an infiltrate of their leukemic cells. They can have toxicity by the various chemo agents, and we know that. They can have rejection of a bone marrow transplant, and they can have ocular involvement with that. So if we look at the classification of ALLs, as I said, we hope they're going to be a common B-cell ALL because that's going to have a good cure rate. But there's some nasty ones. So there's the T-cell ALLs and the hypodiploid and the Philadelphia-like, and they don't do very well at all. So in more than 90% of ALLs, we can find some genetic alteration. So when we look at chromosome number, if they've got less than 46 chromosomes, that's hypodiploid, that's a poor prognostic indicator. If they've got more than 46, that's hyperdiploid, that's good. So, you know, they'll look at the numbers of those chromosomes. Some of them will have a Philadelphia chromosome. Bad news in ALL. Those kids are going to need a transplant. They won't do well at all. Okay, this is the ploidy groups that we just spoke about. So the hyperdiploid, favourable prognosis, usually in the younger kiddies. So these are the high-risk ALLs, the Philadelphia-like, the hypodiploid and the early T-cell precursor. They really all need a transplant if they're going to survive. Sometimes they'll give these kids the tyrosine kinase inhibitors like they have in CML. It may help, but really I think they're not going to risk not giving them a transplant. So the features of ALL in children, the joint pain we said is very common. Kiddies with ALL can have those blasts infiltrating the central nervous system, causing a meningeal leukemia, so they need chemotherapy for that directly into the spinal area and the brain. They have a high incidence of splenomegaly and hepatomegaly, so again you can think of those cells just expanding in those hemopoietic organs. They often have a prior viral infection, and the marrow may be hypoplastic, and as we said, the blood can be pancytopenic before they're actually diagnosed. They've predicted in England that they always get a spike of ALL cases after winter where there's been flu. So they think that virus is another mutation. So they've had the oncogene there in their system, waiting for another event to trigger it into leukemia. So that's been well published. Okay, so we're talking about the CNS leukemia. So this is what they do. They put this little reservoir in so that they can directly inject the methotrexate or whatever chemo they want to give, and they call it intrathecal, so it's into that space, so they can do it here into the spine or into the brain. Because sometimes the child will appear to be in remission, and they won't be able to detect that meningeal leukemia unless they do a scan or unless they've got symptoms like the ocular symptoms. So I think, you know, a lot of that's precautionary. We were talking about tumour lysis syndrome before. So here we go, the hyperkalemia, the hyperphosphatemia, all this cell breakdown, the increased lactate, and all of this thing happening here, the metabolic acidosis, you know, causing the arrhythmias of the heart and cardiac circulatory collapse, etc. Yeah, so pretty nasty. So the B-cell ALL, the patients often present with fever. The blast, we said, had inconspicuous nucleoli. They had a high nuclear cytoplasmic ratio, moderately condensed chromatin. Now, one paediatrician whose talk I went to in Sydney gave this guideline, which is a good thing to remember. In most ALLs, the white cell count is going to be under 10. In 30%, it'll be between 10 and 50. It's only going to be really high in 10% of cases and greater than 100 in 10%. So the majority of cases, the white cell count's going to be under 10. Hemoglobin, you're usually going to expect a significant anemia. Platelets are going to be low in most cases. So if you've got a child, they've got low hemoglobin, low platelets, always be looking for blast cells. Now, the precursor BALL with Philadelphia chromosome can be treated with the tyrosine kinase activity, or the drugs with tyrosine kinase activity, like Gleevec, which is used for CML, and dasatinib, which is the second line of therapy that they use in CML. Infants in the first 12 months of life can get an ALL which is very nasty. They don't do very well at all. It's quite different disease to that you get in toddlers and older children. Their disease-free survival rate is 20 to 30%. They don't do well at all. And they tend to have this 411 translocation involving the MLL gene. So these kids tend to have more CNS disease as well. So, and if they're a twin, there's a high chance that the identical twin will get the same leukemia. Okay, we said the T-cell ALLs are pretty nasty. They can get these children or adults into remission, but they relapse very quickly. So that's why they try to get a donor for a transplant. And so quite a nasty disease. Half of them will have a mediastinal mass, so that might create some symptoms, respiratory or breathing symptoms. And their morphology is quite variable. The nuclear pattern is quite pleomorphic, so they might be a bit irregular and folded, and quite often they're a lot larger than your B lymphoblasts. So here we've got, thank you, evidence of a mediastinal mass. So this is TALL we're talking about, very poor prognosis. Okay, a little bit there on the markers. And you know with any of the T-cell markers that the immunophenotype points to the T-cell lineage, but we definitely need the gene rearrangement studies to prove the malignant clone is present. Burkitt, well, there's 3 types of Burkitt, aren't there? There's the endemic that we see in the, typically in children from Papua New Guinea and Africa, where they've got the bulging jaws, the infiltrate of those, and it's associated with EB virus. We get the HIV-associated Burkitt, and then we get sporadic cases as well. So the ones we probably see, and we don't see that many, are probably the sporadic ones. So they've got very basophilic cytoplasm, quite vacuolated, and there's some children with that horrible endemic form of it where they've got the infiltrate of the tumour, that big sort of bulging cheek and jaw. So this was first described by Burkitt around 1960 as a highly aggressive non-Hodgkin lymphoma. And so there's the different variants, but we also have some morphologic variants. Classic Burkitt or atypical or Burkitt-like. And so you'll find the histologists, they'll examine the nodes and the morphology will be a little bit different to what we get. The nucleus might be a bit folded and they'll call it a Burkitt-like lymphoma. It's probably all very similar. So the Burkitt-like variant, greater pleomorphism, that's what I was saying about the morphology. Pure nucleoli. Sometimes the cell is between a diffuse large B-cell lymphoma and Burkitt, and we've had diffuse large B-cell lymphomas that have been treated and transformed into a Burkitt, so there's a bit of overlap there. Okay, that's some Burkitt cells in a marrow, so very vacuolated. There's a bit of differentiation here between the diffuse large B cells and other lymphomas, but we won't go into that. So a lot of the Burkitt lymphomas have a translocation involving chromosome 8, so it could be an 814 translocation or an 822, and whether it's one or the other will dictate whether they have this c-MYC oncogene and whether they've got a kappa light chain or a gamma light chain. So a lot of the Burkitt cases have the 814. So treatment, a bit like that we have with ALL, induction, consolidation and maintenance therapy. And we know that the Burkitt cells are CD20 positive, they're B cells, they'll be CD10 positive, the lymphoblast marker. So they can use rituximab therapy, which is anti-CD20, to treat them like they do with some of the CLLs. Okay, how are we going? Do we write for some chronic leukemia? We're a bit bored with blasts. So chronic myeloid, we see this quite regularly, don't we? It's one of the myeloproliferative neoplasms. So we need the Philadelphia chromosome, which creates the BCR-ABL fusion gene, for a diagnosis. And typically on the blood film, we've got a range of maturity of the myeloid cells. We've got 2 bands of cells in predominance, neutrophils, early myeloid, so myelocytes and metas. They're the big group of cells. We'll get small numbers of blasts and promyelocytes, an increase in basophils and or eosinophils. So that's the classic picture of a chronic CML. And they'll typically present with a big spleen because all that activity is happening in the spleen. So what I find with CMLs, I find people miss basophils. I don't know what they count them as. Whether they count them as toxic neutrophils, I don't know, but I get cases coming in and I think, oh, there's basophils here and they haven't been counted. So, yeah, always check. Sometimes their granularity is not like the classic textbook basophil. So here, that's easy to see, that's a basophil there. And that's exactly what we said. On the bone marrow, they're going to have marked myeloid hyperplasia, so a really increased ME ratio. So we know this CML involves the translocation between chromosomes 9 and 22, which results in the Philadelphia chromosome. So it's a reciprocal translocation, and this results in the ABL and the BCR genes being close together to form a fusion gene. Now that gene produces a gene product which has tyrosine kinase activity, and this drives the whole production of white cells. So all of the myeloproliferative disorders produce cells, so there's peripheral cytoses, uncontrolled proliferation without the influence of any cytokines. So it's autonomous production of cells. And this is happening because of this BCR-ABL fusion gene, and it's got strong tyrosine kinase activity. So when they developed the tyrosine kinase inhibitors, that was great news for people with CML. Before that, the only cure was a transplant. A lot of patients were on hydroxyurea or interferon. None of those cured them.
So with the ALLs that have the Philadelphia, do they've got increased tyrosine kinase activity as well?
Can treat
Is that
them.
why they have a poor prognosis?
Well, they can treat them with the tyrosine kinase inhibitors, but they don't do well. They don't go into remission with it. Yeah. So this is whichever cartoon you like to look at. So we've got, part of the ABL gene has come off here, and part of the bottom of this one's gone down to this chromosome 9, and we've got the BCR and ABL close together here to form the Philadelphia chromosome. So we've chopped this bit off here, we've chopped that bit off there and put it down here, so it's what we call a reciprocal translocation, or you might prefer this coloured version. And so the disease has got 3 phases. It's a triphasic disorder: chronic phase, accelerated phase, blast crisis. Most of the patients we're going to see in chronic phase, they're going to present like that. Big spleen, the doctor sends them along for a full blood count, we see the high white cell count, etc. There's a big spleen, but I don't think he's doing too well. We'll get past that. So chronic phase, we've got all of those myeloid cells increased, basophilia, and the bone marrow is hypercellular. And it looks like that, doesn't it, the peripheral blood when we see them. And it means we've got to do all those calculations, the white cells causing the turbidity interference and all of those things. So the bone marrow is going to be really hypercellular. In the accelerated phase, you might be getting an increase in the blast, but you might just see an increase in the basophils, and that might alert you. This is heralding an accelerated phase of the disease. And the platelets may suddenly drop below 100 or go above 1,000. The patients are probably still on therapy, but clearly the white cells gone up, the platelets have either plummeted or gone through the roof, hemoglobin's dropped, the blasts are going up, the basophils are going up. This disease is transforming. The blast phase, greater than 20%, so it's actually an acute leukemia now, and it can be anything. It could be, the blast crisis could be myeloid, lymphoid, erythroid, or megakaryocytic. If you have a lymphoid blast crisis, those patients tend to skip the accelerated phase. They go straight from chronic phase to blast crisis, so they don't do very well. And when they're in blast crisis with the lymphoid one, they're going to be treated like an ALL. There's a myeloid blast crisis and a lymphoid blast crisis. So mostly they'll be myeloid, but you will get some of the lymphoid ones. So the treatment, we're going to use the tyrosine kinase inhibitors. They started off with imatinib mesylate, known as Gleevec, and depending where the patients are is the spelling of the drug, and that inhibits the tyrosine kinase activity. So it's the tyrosine kinase activity that's causing the signals to be transduced for the white cells to keep increasing. Some patients didn't do well on imatinib because it has some side effects, photosensitivity, gastric problems. Patients didn't like it, not really compliant, so might have gone off the drug on and off and they became resistant to it. So then they've got second line of therapies, dasatinib and nilotinib, and the patients seem to accept that a bit better. But I think they have to be on Gleevec first before they can be eligible for the other treatment. So here's the BCR-ABL fusion gene protein. It has a binding site for ATP. So when ATP binds, it loses a phosphate moiety, which phosphorylates the substrate. And this causes the increase in the white cells. So it's saying more white cells, more white cells. If we block the binding of the ATP with the tyrosine kinase inhibitor, well, ATP can't bind anymore, so it can't phosphorylate the substrate and you don't get the signals. So effectively a cure. Yeah. When the patients, are not compliant with the drug and they develop resistance, this fusion gene protein is pretty smart and it changes the binding site. So science is pretty amazing, isn't it? So if it's a young patient, they might still consider a bone marrow transplant. CLL, well, we get heaps of those because we're getting an ageing population, aren't we? And we get this progressive accumulation of these mature B cells. They're not dying off, so they're just proliferating. Yeah. So they look like mature lymphocytes in the peripheral blood. They've got the B cell markers, and they co-express the T cell marker CD5. So the two lymphoid disorders that particularly have that profile are mantle cell lymphoma and CLL. They both co-express this CD5. In CLL, they've only got a weak expression of the surface membrane immunoglobulin, which could be restricted to kappa or lambda. Mantle cell, it's a lot stronger. Mantle cell's a nasty disease. Okay. So this BCL2 proto-oncogene is overexpressed in BCLL, and so you're getting a suppression of apoptosis. So cells aren't dying, they're just staying there forever. And we often get an abnormal carrier type. So these patients could have a deletion of the 13q, trisomy 12, etc. So the patients might present with, lumpy glands. Often it's picked up incidentally. We're doing a full blood count, their age profile tests, and we just find they've got a significant lymphocytosis. We do the flow cytometry and find, they've got a clonal population. So initially, they're not going to be treated if they've got no symptoms, because the treatment will probably cause more problems than, if they didn't. Obviously, if they've got big lumpy glands like that, they might get treated. Okay, so the phenotype, here we go. We can compare the BCLL to mantle, lymphoplasmacytic leukemia, which used to be called Waldenstrom, and a follicular lymphoma. So you can see the similarities and differences there between those different groups. And this is our typical CLL. We call them soccer ball lymphs because they look like a soccer ball. You might call them crack plates, or I'm not sure what they call them at uni now. Do you have any? Do they describe them?
I've heard the butterfly one, I've never heard the soccer ball.
Yeah, soccer balls. And it's because the chromatin is so clumped, you're getting those clear areas of parachromatin. So really mature. We just count them as normal lymphocytes. One of the side effects that you can get in CLL is an autoimmune hemolytic anemia. So if you've got a CLL and the hemoglobin's dropping, it could be that the CLL lymphs are crowding out the marrow and other spaces, but it could be that they've developed the autoimmune hemolytic anemia. 20% of patients will get an autoimmune hemolytic anemia with their CLL at some stage in their disease. A lot of them will continue to be Coombs positive even after the spherocytes are gone. And so, they're usually going to treat them like any autoimmune hemolytic anemia with steroids. Okay, so there's a few spherocytes here on this film here. Probably not a great photo, and there's some increased polychromasia. So you're always looking for that in a CLL patient where the hemoglobin's dropped. So transformation of CLL, usually we see prolymphocytic translocation or transformation. So we allow up to 5% prolymphocytes in a CLL. When they've got between 5 and 55%, it's said to be CLL/PLL or transforming to PLL, and greater than 55% is known as prolymphocytic leukemia. Some patients will get a blastic transformation. We don't see these very often because it's usually in the tissues, and that's known as Richter's transformation, and it's really nasty. What we know about the progression of the disease, and there's a couple of tables or staging systems that we use, the RI or the BIN-A. The RI, they tend to use, it has like 5 stages, so it might start off with a lymphocytosis and no symptoms, and they might have a median survival of 10 years. As the disease progresses, the doubling time of the lymphocytes is going to decrease. So where it used to increase every year or every 2 years, where it used to double, now it's doubling every 3 months. That disease is progressive. Then the platelets and the hemoglobin are dropping below 100, and that's, really late stage. And, their survival at that point might be 6 months. So they'll be looking at the beta-2 microglobulin, which we look at as a prognostic indicator in a lot of lymphoid disorders and myeloma. So the decreased doubling time, if it's less than 12 months, poor prognosis. Oh, here's this RI staging here, so you can just look at that now because I've said it all. So the BIN-A is the French staging system, which has 3 stages. Okay, so the treatment, we can use nucleoside analogues like fludarabine. If patients have fludarabine therapy, do you know they have to have irradiated blood if they need a transfusion because they can get like a graft versus host reaction. They can have cladribine, which is also used for hairy cell leukemia, and pentostatin, which is deoxycofomycin, which is also used for hairy cell leukemia. Now they're tending to use this ibrutinib drug for elderly patients, and it binds to this Bruton's tyrosine kinase. So these tyrosine kinases have got a lot of activity in these malignant disorders, haven't they? And they also use monoclonal antibody therapy like rituximab. So we're seeing now, we get CLL patients who are on treatment, don't have lymphocytosis. So some of these treatments will kill off the B cells, but some of those more resistant cells like the prolymphs, we're starting to see those at a lower lymphocyte count. Alemtuzumab is another monoclonal antibody therapy. It's an CD52. And this new one, ofatumumab. So any of these with MAB on the end are monoclonal antibodies. So this is another anti-CD20. Okay, the genetic lesions. We spoke about 13q and 11q and the trisomy 12. So, the more lesions, cytogenetic abnormalities, of course, the worse the prognosis. And you can see that in this Kaplan-Meier survival curve. So if you've got the best one to have is a 13, or probably not. None of them are really good. These are obviously really bad, so that's the 11q, and this one here is the 17p deletion. So, they've got survival figures for all those genetic translocations. Chronic eosinophilic leukemia, we don't see a lot of these, and so it's difficult to know whether a patient's got hypereosinophilic syndrome or chronic eosinophilic leukemia. We can look for a genetic translocation. We look for a deletion of the CHIK2 gene, which corresponds to a FIP1L1 platelet-derived growth factor alpha mutation. And so that can more closely suggest a chronic eosinophilic leukemia. Hypereosinophilic syndrome's been known for a long time, and they used to say you needed an absolute eosinophil count greater than 1.5 for greater than 6 months where there was evidence of damage to organs or tissues. So we know eosinophils are nasty cells. They've got toxic cationic proteins and eosinophil peroxidase, and they damage tissues like cardiac tissue and spinal tissue. So, yeah, they're nasty cells. They're meant to kill parasites, and, you know, they get over-enthusiastic and, you know, get a bit out of control. So these patients will have hepatosplenomegaly. They can be treated with the Gleevec, and they do very well under that treatment. So it's a diagnosis of exclusion, the hypereosinophilic syndrome, whereas the chronic eosinophilic leukemia needs identification of one of those changes. These are actually all eosinophils here. They've all totally degranulated. Sometimes you'll only get the clue by the chromatin pattern, or maybe it's just this pale blue cytoplasm. Chronic myelomonocytic leukemia, we see more and more of those because of the ageing population, and so the myelomonocytosis. And yeah, so we might sort of rush through this a bit. We're used to these pictures. We get quite dysplastic looking monocytes sometimes, and I've recently done a little thing on dysplastic changes because I think staff have trouble knowing what does dysplasia mean. It means an abnormality of cells and tissues or an inability to properly mature, so we're going to see lots of morphologic changes that we can attribute to dysplasia, but not every abnormality on a film is dysplastic. Okay, so the features of a lot of leukemias and lymphoproliferative disorders, the night sweats, the fever, some of these are due to the cytokines that are released, the bleeding due to the thrombocytopenia, the big liver and spleen. Hypercellular bone marrow blasts are going to be less than 20%, otherwise it's going to be called an acute leukemia. And they're going to have dysplastic changes in white cells and monocytes and platelets. So poor prognostic features are if the hemoglobin's low, the platelets are low, the white cells are high. And if we've got lots of early myeloid cells and a high percentage of marrow blasts, and you'll know that they have CMML1 and 2 depending on the number of the marrow blasts. Something that's a little bit similar is the juvenile myelomonocytic leukemia. Now this is a much worse disease for children than ALL. These children, if not treated, if they don't receive a transplant, they will die within a year. And you have to be, I've been talking to people today, you need to be very wary if you've got a toddler with a monocytosis, always have in the back of your head that it could be JMML. Now some of these kids will revert to fetal hemopoiesis, so if you do a Kleihauer, that can be positive, that could be a clue. Some of them are associated with the neurofibromatosis gene. So they can present with similar symptoms to a child with infection, because remember the monocytes are infiltrating those mucous membranes, respiratory tract. They might present with a respiratory infection. Could be the infection. Monocytes are good at cleaning up after neutrophils, but it could be JMML. So always have that at the back of your mind. And yeah, they need to be monitored. So they can also have the skin rash. We said the monocytes can infiltrate the skin. And, you know, they can have some blasts, of course, and the elevated hemoglobin F. So 15% of cases are associated with the neurofibromatosis gene, ultimately fatal if they don't have the right chemo. So what I recommend to our staff, if you've got a child in that age group, they've got a monocytosis, always let a haematologist know so they can talk to the referring doctor and just let them be aware this child needs to be monitored. Yeah. Okay, so they're just going to have monocytes, some may be abnormal. Hairy cell leukemia, really a lymphoproliferative disorder. I don't like it being called hairy cell leukemia. Patients think they've got a diagnosis of leukemia. That's not very good. It's a lymphoproliferative disorder. It's quite treatable. The typical case is a middle-aged male, pancytopenic, monocytopenia, so not many conditions have a low monocyte count, and yet the instruments may count the hairy cells as monocytes. So if you've got a monocytosis from your instrument, just be sure they are monocytes and not hairy cells. We know that they have fibrosis of the marrow, so if you've got layer upon layer of fibrotic tissue, you're not going to be able to suck out individual cells, so they're not going to be able to aspirate marrow. It'll be a dry tap. So they're generally diagnosed from a trophine. They have a very specific marker, CD103, because we've got other disorders like splenic marginal zone lymphoma and hairy cell variant, which have got villus projections. So this is the marker that we want for hairy cell. And here's some hairy cells here. They've got sort of dirty looking cytoplasm. It's a bit of a fringe all the way around the cell, and the chromatin's quite spongy or reticulated. They're a moderately large cell, and so a little bit different to the splenic lymphoma cells. This is the bone marrow trophine, and you know the haematologists refer to it as starry sky because there's these little clear zones around the hairy cells that makes it look like it sparkles. I haven't seen that yet, but I haven't seen a starry sky like that. So the treatment, generally cladribine, one course and they're in remission. They used to take out their spleen because they knew the hairy cells would produce it, but taking out someone's spleen has some nasty effects. This is the hairy cell variant, so the cell is midway between a prolymphocyte and a hairy cell. Okay, so we've got a little quiz here. I might get Holly to hand out some chocolates.
She gets a good job.
Yeah, so there's those as well. Okay, so with respect to CLL, which statement is false? It rarely occurs in patients less than 40 years of age. It's B-cell origin. The cells have a heterogeneous population of reactive cells. As the disease progresses, they get hypogammaglobulinemia, and it's often found as an incidental finding. So which one of those do you think is incorrect? Which is false for CLL? Probably the third one, isn't it? Yeah. You can get it in patients younger than 40, not very often. It is B-cell. They do get hypogammaglobulinemia and often an incidental finding. Okay, so that's the correct answer. What are faggot cells?
The last one.
Cells with bundles of our rods. Another chocky coming up. That's right. If our rods are seen in blasts in peripheral blood in a case of leukemia, what is the leukemia likely to be?
Number 3.
Yes, another chocolate.
All right. I'll sell them after.
Okay, the Philadelphia chromosome results in the reciprocal translocation between which two chromosomes?
9 and 20.
There's a 9 and 22. There you go. That's right. What is the minimum number of blasts needed to confirm a diagnosis of acute leukemia?
3 is an increased in.
Fourth one? Who said that? Okay, got a chocolate there.
You can just chuck them at us. I feel bad. Oh, I probably into someone.
So with CML, which of the following statements is false? Silence. Usually thrombocytosis, isn't there? Okay, chromosomal translocation 1517 results in the abnormal retinoic acid receptor, and that's found in
APML.
Okay, so a few chocolates there, Holly. Come on, don't take them home with me. With respect to AML, which statement is false? No. That one? Oh, false. Yes, that's right. That's false. Yes, that's right. AML with monocytic differentiation is usually positive with which set of monoclonal antibodies?
The last one.
There you go, right. occasionally a mild to marked eosinophilia may be observed at diagnosis of ALL. What's the cause of the eosinophilia?
Yeah,
Second one, yeah. So we get some lymphokines that stimulate the production and differentiation of eosinophils. Major complication of APML?
DIC.
Yeah. Okay, the patient's got a mediastinal mass. The white cell count's 54. What's it likely to be? First one? Yeah. TALL. That's all. So, sorry that was a long and involved session.
Oh, that was very good.
So do we have to say goodbye to our friends?
I'm just going to ask the regents, has anybody got any questions for Lyndall before we let her off the hook?
They've all gone to sleep.
They're on the whack. I can see movement.
That one just shook his head.
Wayne, I think.
I think we'll take that as we've stunned you into silence.
Excellent.
Is there anybody here in Townsville that has a question for Lyndall before we go? Everybody's hungry. Thank you everybody for attending, and can we all please thank Lyndall very much for a very understanding